Thank you. Yeah. Good morning, everyone. I'd like to thank APO and AIOS for giving me this opportunity. So my topic today is why I prefer refractive EDOF. Now we are in the generation where no more 20/20 or 6x6 vision is not enough. Patient wants more. And the problem is the more options you put into the lens, you're having some kind of a compromise. Now, for instance, let's say if you want the best quality vision, monofocal is the best, but you have very less presbyopic correction. But if you want 100%, at least maximum presbyopic correction, like a multifocal or a trifocal IOL, but you have a compromise in quality of vision. So this is where the refractive EDOFs come into picture, where it has a perfect balance between presbyopic correction and visual quality. Now, the main thing what happens here is there is no splitting of light. That is how it's able to maintain quality of vision. And the new generation refractive EDOFs, actually, the halo profile is almost similar to a monofocal level, including the dysphotopsia. As you can see here, hardly you can, if you look at the profile, all the three dots on the right, you hardly can make out difference which is the refractive EDOF. That is the quality of vision it's trying to deliver. Even if you look at the visual symptom questionnaires given to patients, it's very similar to that of a monofocal IOL. Now, the other thing, what happens in a diffractive IOL, there are certain criteria what we have to look at, right? But in a refractive IOL, because it behaves like a dysphotopsia profile is like a monofocal, so the workup is just like any other monofocal, and you don't need to invest in very high-end machines to look at it. So if a person specifically is not using presbyopic IOL currently in their practice, this is the best lens to start off with, because this is a very forgiving lens, and and the best part is you hitting a 20/20 vision is more likely with a refractive EDOF than a monofocal. That is because it has a little landing zone from plus 0.5 to minus 0.5. So anywhere you have a post-refractive error landing anywhere in between this, you will have a 20/20 vision. That is why it is the best lens to start off with. And definitely, as you know, that neuroadaptation also is much quicker in a refractive EDOF patients. Now, the main point about these patients is a lot of times, before refractive EDOFs came into the picture, a lot of eyes with hyoid aberrations or some other eye issues, we used to exclude them for any presbyopic lenses. But now it has completely opened a new set of patients who are suitable for a presbyopic correction, even though they are not non-pristine eyes. So as you can see here, even in mild maculopathy, glaucoma, amblyopia, all these kind of conditions, 90% of the patients were satisfied with the vision, and there was a significant improvement in vision too. Now here you can see in glaucoma patients where it was implanted, and you can see the contrast sensitivity did not decrease in EDOFs, and also postoperative visual field remained stable too. Here's a set of patients which was operated in radial keratotomy with refractive EDOFs, and then 79% of the patients had better than 20/40, and 62.5% achieved the target refraction, and so on and so forth. Now here, you can see it's been implanted in an age-related macular degeneration. And again, the patient, the eyes with early ARMD maintained normal contrast sensitivity and had good vision. But when you combine this with the micromonovision, it works really, really good. So when you target a micromonovision of 0.5 or 0.75, that's when the patient bilaterally almost has 20/20 vision at all distances. To summarize, basically, night driving refractive EDOFs are really good. Neuroadaptation is much quicker as compared to a multifocal. Dysphotopsia is very minimal, very similar to that of a monofocal. The range is more smooth, not like step-like like a trifocal. And patient happiness also, usually patients are much happier with this particular lens. But the issue is that whenever we think of a presbyopic IOL, we have so many options in the market, and we really don't know. Forget about explaining to the patients, we ourselves find it difficult to understand. So what I do is I make it very simple. I categorize into diffractive and a non-diffractive. So even future lenses also, you can just put into any of these two criteria. But again, how do I decide whether I have to implant a diffractive or a non-diffractive IOL? So this is my decision tree. If a patient wants presbyopic option, first I see if the patient is suitable for a diffractive IOL. So this is my decision, if at all it's suitable for all these categories, then if the patient is normal or not a type A personality, then I simply go with a diffractive IOL. But if the patient is a type A personality, and then you can simply push over to a refractive EDOF or a non-diffractive IOL. And if the patient is not suitable for a diffractive IOL, then either if it is only high odd aberrations, you can either regularize the eye and then push to a diffractive, or you can simply go with a non-diffractive IOL. I think this is a simple decision tree which not only makes it simple for the doctor, it makes it so much more easier for the patient to decide. Even a workflow also will become so much more easier.